Hello, thank you for joining us on this week's Coffee with Doc with Dr. Brock Johnson. First off, a quick disclaimer. The content provided in this podcast is intended for informational and educational purposes only. It is not a substitution for professional medical advice, diagnosis, or treatment. Always consult with a qualified healthcare provider for personal medical advice. Any medical decisions should be made in consultation with your healthcare provider, who will consider your individual needs and circumstances. Whether you're a medical professional, a patient, or someone interested in improving their well-being, we got something for you. Go ahead and grab your favorite cup of coffee and let's dive in.
Hi, I'm Doc Brock. I practice chiropractic neurology, functional medicine, and we're here at Neurologic Rehab and Wellness in Garden Grove. So today's topic is hand pain, numbness. How do you fix it? What do most practitioners do to treat it? Or do we treat it, or how we treat it here? So the differences. So I'm breaking down the nerves involved, median, ulnar, and radial, and components of where it starts from the neck. So the neck can cause issues creating the hand numbness or pain. And as it comes through the division of all the muscles and spaces that it can get entrapped, we call them peripheral nerve entrapments, or nerve entrapments peripheral, outside of the spine. So a lot of times when doctors are talking, especially orthopedics and surgeon types, they're only looking at the spine of the neck because that's where they do surgeries on bones. But really, most entrapments, most numbness or pain patterns are created in muscles or from muscles. So if it's pinched in a muscle, it'll hurt in a certain way, and it depends on which part of a muscle or where the muscle is, how it catches which nerves. So they're very specific in how they run through muscles or turn. They actually spiral coming out of the neck and spiral over into the hand. So most of the time they're non-surgical. Of course, there's cases that are so severe that you do need surgery in the spine, and they're really serious stuff. But for the other 95% of the time, we just have numbness and pain patterns. And in this speech, I'll go through which part and what nerve will give you some light into how to fix it and where not to go, really. Stuff you can do at home too. But do you have any added in to start with?
I just want to welcome all of you that are on Zoom. We're just so grateful that you're here with us, and we're so excited to be able to teach you a little bit about not me teach you, but him teach you a little bit about what's going on with your fingers, hands, and arms.
Yeah, and she'll keep me on track because I'll go off into tangents about something, and she'll just bring me right back. I forgot to bring her whip.
And his moral support.
Yeah, yeah, that's true. You're the pretty pet.
I should get a license for that.
Oh, that's true.
Pet? Oh, thank you.
Well, you're doing you're counseling. You're going through counseling, so that makes sense. You're just guide me.
Okay. Here we go. Here's our friend.
Yeah.
If you have any suggestions on what we should name him, please send us those suggestions, because he's here all the time with us.
Oh yeah, he was weightlifting in the gym during Halloween, and we had him on a table for most of the time. Now I'm bringing him out, and Skinny Bone Jones is all I could think of. So we'll see. But as I go through the bones, it's easier to see. I wish he had some more meat on him. That'd be easier to see. But I drew terrible pictures too. So the most common, things we hear about, what it is and what it. So carpal tunnel syndrome. That's always the first one I think about. You always hear about it. Anyone that works at a desk with their hands in pronation. So you're typing down, fingers down. That has a lot of entrapments on the inside of the arm, and as a result of that, you'll go see a primary or some other doc, or just friends will tell you, oh, it's carpal tunnel syndrome. So you got to get this in surgery, or under the AMA, the surgeons will go in and they'll cut the wrist in half, because these are the carpals. So in Skinny Bone Jones, they have the median nerve. So we're starting with median nerve, and the median nerve will run out of the neck through the brachial plexus, in between a muscle, actually piercing right through the muscle of pronator teres, the muscle that turns your hand down, and go into the hand. And a lot of times it's not entrapped in the carpals. There's lots of space for nerves. It's designed for nerves. Anywhere there's a bone space, it has formation around it for holes and things to go through. So not usually trapped in bones, but in the muscle part, most often they're trapped in the elbow. So slicing your wrist in half every day, you don't want to do that. It's a very strong tendon called flexor retinaculum. So it's a huge sheath that holds 8 of these carpals. You have 2 rows of carpal wrist bones, and that one sheath holds it all in together. And there's other components, that's the main one. So when they misdiagnose this, you have numbness in your thumb, your forefinger, and your middle finger on your palm side of your hand, and it hurts in the wrist, and it's starting to get weak in the hand, and I'm squeezing things or opening jars. The AMA will go to the wrist, and then by design, they'll just cut the wrist in half. But get tested first outside of the AMA, come to me, or anyone that has a little bit more knowledge into muscles, because we're looking at entrapment sites for median nerve under the armpit, because we usually sleep crunched in all night, and then that pinches the nerve off a little bit, or turning or typing or any fingers down, hand down kind of pronation move. But the numbness patterns are the thumb, which is first digit, second digit, index, and third digit. So you have your first 3. So this is the numbness pattern in blue. And that puppet hand is actually thumb. I had a right thumb in because you can't really tell. But this is the numbness. So when you have median nerve entrapments, most of the time entrapped in muscles, you're going to have numbness in these first 3 fingers. And you'll have pain in the wrist. And it usually comes from the elbow or entrapped under the armpit. So under AMA, they're slicing wrist in half and doing more damage, I think, personally. Most of the time it's just a misdiagnosis because they won't go through. All you have to do is release muscles. I call it the prom wave. So the nerve pierces right through a muscle called pronator teres, and it turns your hand down. Well, if you contact that point just before skinny bone's hand, so we're just towards the hand but at the elbow. So we're at the elbow but like an inch towards the hand. And you pinch it, you compress it, and then I call it the prom wave, where you just turn your hand back and forth. That's how the muscle runs anyway. That's the job of the muscle. So when you push in there and you turn, and the action is by pushing here, it brings in blood flow to the muscle and opens it up so the nerve can conduct faster. So when you're compressing nerves, it just slows down the speed, and then the muscles don't behave. You'll have this pinky to thumb weakness, and you're opening jars, and you have the pain. But do some prom waves, and you can open that up. Also, in the office, we also we go back to the neck. So if you have an unstable neck, particularly at C6, C6 is the nerve that carries that muscle tone. So we stabilize the neck with activators, turning on muscles so when you move, the bone moves safely around the nerve. So I would come up to bony, percuss the muscle back, which then, as long as the brain knows where that bone is moving when we move our head or we're sleeping in positions, it'll start firing faster. And that's pretty much the idea about anything connected from brain or nerves. The control system has to move at 80 times a second, extremely fast. And if it's compressing a nerve, that slows it down. Or if the neck isn't moving safely through proprioception, the brain detects, it's not moving right, I'm just going to slow it down. That's how it casts in. So there's a safety stabilizing mechanism in our brain as a reflex. So if anything doesn't move right, the brain slows down the nerve and it casts us into flexion. So if we have an unstable neck and we're sleeping on our shoulder all night, it'll wake up with a numb hand. And it'll be weak and painful in the wrist. So that's carpal tunnel syndrome, misdiagnosed. So it's a median nerve entrapment, most often in the elbow or in the armpit. So it's not a true carpal tunnel syndrome, but it's always commonly misdiagnosed. So any questions on carpal tunnel?
So if you're like me and you're always typing because you're a student at 41 with 7 children and you don't get to sleep much, I always complain that my 2 fingers are numb, right? and I always want you to pop my wrist because that's what my
Oh.
chiropractor would do before,
Yeah.
and it felt good. But you always tell me,
But is it
no.
most often there?
And
No.
I'm saying, why? It feels good. So why shouldn't we pop our wrist or our elbows?
Yeah, because you can adjust. It's okay to pop outside the spine. You're popping knuckles, wrists, elbows. If you pop in the spine, it's a nerve. I mean, there's a spinal cord there, so the brain has set up reflexes to protect you. You start popping areas of the spine like the neck, rotary breaks, really hard cracks, self adjustments. You're gonna start turning off these muscles that protect it. So extremities, yeah, pop a wrist is fine. Crack your knuckles, do an elbow, but is it gonna fix the entrapment? No, it's stuck in muscles. So you got to go through the muscle work, like the prom wave. You can stretch and hang. You'll open the armpit so you can get the nerve to run faster. But basically, carpal tunnel is, when you back it up for true diagnosis, if you said, oh, this is a real carpal tunnel syndrome, this is the less than 5% of the time that this issue with the pain and numbness here is going to be not maybe in muscles, but in a wrist. Maybe there's an osseous entrapment. So this is the lesser real carpal tunnel syndromes. They're diagnosed through EMGs. So I certified in EMGs a long time ago, but you put needles in muscles, and then it's attached to a wire. It's a test where you can hear the firing of the muscles from that nerve. So you'd put a few needles in the hand, like the thenar eminence here, which is controlling Ponen's pollicis grip, and you put a needle in there, and then you hear if it's firing off or it's just really slow. You can tell on a needle EMG. And then you do an NCV, a nerve conduction velocity, so you shock it. So it's a two-part test. You put a needle in the muscle to see if it's dying away or the nerve isn't firing fast. And then you shock it to see how fast that nerve is conducting. But you have to be very, very good and proficient at doing electrodiagnostic studies with the needle and the tasering to get an accurate, because it could be trapped. I'm not saying carpal tunnel doesn't exist. It's a lesser common thing. You could be entrapped. I've had patients who put in blinds and construction stuff, and they would hammer. I mean, it's just blind, but they would hammer with their wrist to like finish it up instead of a tool. They're using the wrist as a tool. So they had a true like damage to the carpal tunnel. There's lots of injuries and pathologies in hand. What if you fractured a hand or lots of injuries that could be entrapped here. But the main thing is that they're mostly released in the elbow. So carpal tunnel is a real thing, and it could be diagnosed with electrodiagnostic studies and measuring. But the best thing is just a practitioner looking at you, testing reflexes, opening the wrist, all kinds of things. Those are better. Welcome, guys. We're zooming live for hand pain and numbness. That's our Saturday thing.
Yeah.
Oh yeah. Well, they can go around, right?
You guys can go around over here.
Yeah, there's a door you can go around and get right to it. How are you? So that's carpal tunnel. So true diagnosis, electrodiagnostic studies, muscle weakness, atrophy, a good exam, that'll show you. You could even image it. There's lots of MRIs that could look at that. But carpal tunnel is a pretty rare thing, and most of the time you really don't have to worry about it, barring like trauma. Trauma is pretty obvious if you get a truck rolled over your hand or you fracture it and you got to look at entrapments in there. Those are common. I want to move on to ulnar. The ulnar nerve is a part, it carries the other two fingers. So this is digits 4 and 5, pinky and ring finger. And we're looking at, for sensation, it carries the lateral hand and those two fingers, usually palm side. And it could actually cover a little bit. So palm side, pinky, and thumb. So when you go to test it, you'll have weakness in these fingers. They'll roll, or you can't have your thumb flat to your fingers. So that's flexor pollicis or adductor pollicis. So the thumb carries all three nerves in the hand, and the fingers are divided. But the thumb flat like that, we call it a knife hand. You have a good knife hand, not curled in for a cross, but like flat. And resisting that, that's an ulnar nerve, or these two little fingers. But what you'll find is that this hypothenar eminence on the outside of your hand will atrophy, and that'll be, I mean, that's a severe one. But Normally you just have numbness and a little bit of weakness, and that's how we detect early that it's ulnar entrapment. So ulnar nerve. So for ulnar nerve is the pinky and ring finger down the hand. So this is ulnar, and previously we were talking about median nerve. So they're split. These two and these three are two different nerves. On the palm side of your hand, ulnar comes off the neck, or before it becomes ulnar, it comes off the neck at C8, which is a little bit of a lower portion of the neck. There's traumas if you have an outstretched hand, you fall, or and you rip something in the neck or brachial plexus, that could do an ulnar entrapment or a pathology to the hand. Those are pretty much the tests. So if you have numbness on, there's the thumb. So numbness on skinny bones, these two fingers. The most common entrapment, there can be a portion in the carpals also, because median nerve comes through one side of the wrist, ulnar through the other. But really, everyone's hit their funny bone. So you get this little knock in the elbow and it zings. That's the ulnar. So when we're going through tests, electrodiagnostic studies, and we're looking at these good nerve speeds, we always saw a little bit. Everyone had something wrong, a little history, like old damage to the ulnar nerve. It would spike a certain way when you're looking at the EDXs. And you could tell that, there's old. So we just got used to everyone having old funny bone issues, which is a pinch or a compression in the ulnar. It'll heal and everyone is fine, but you can tell the history of it on the EDX. So the pinky and thumb numbness and weakness there, and like that, you can't close your hand, or take a piece of paper and you try to flatten it. It's called the Frohman's test. You have this really good knife hand, you slip a paper in and drop them on the floor, and then you try to pull, and if you cannot pinch a paper in your hand, it's usually an indication of a weak muscle there, which is usually a nerve entrapment, so it's usually carrying through the elbow. So ulnar nerve comes out of the armpit too, so you can also be sleeping on it and have issues and compress that. And it carries right through the ulnar groove here and into the hand. So if you're just loosening up, not the prom wave from the front, but just a little bit from the funny bone up towards the shoulder, that's the most common space of where the ulnar is entrapped. You can stretch it, you can traction it, you can put cream on there. In the office, we stabilize the neck with the activator C8 and strengthen some of the shoulder components so they're back, and then we loosen up from armpit to elbow all the way down. That opens up the nerve for the pinky.
It's really fun when you're laying on the table and your doctor sticks his thumb in your armpit. It's really an interesting.
It's the best time.
Like, what are you doing?
Under massage therapy license, they don't allow them to go into the armpit in these spaces, but actually that's most common. That's where they're entrapped. They're just trying to protect their licensures, because there's a lot of vessels and nerves that run through the armpit, but that's usually where the instabilities in the shoulder and the compressions and the bad sleeping cause the pain patterns. So I want to show the Frohman's test again. So that's just an office one. Do I want to? Okay, here's one. So on my lovely model, she will test the Frohman's test. So you would have your hand straight like a knife hand. And what I want to do is have a paper come right into this grip, and then she go ahead and pinch it. And if I can't, so I'm going to bring the paper, and you grip that. And if I can easily just slide it out, or she cannot resist this without turning the hand in, but keeping it as flat as possible, you just had an ulnar entrapment. Now that's a negative for a Frohman's test. And this negative is good. You don't want a positive where it's atrophied, it's weak, and the nerve isn't conducting well to the muscle. So if it slides out with ease and you cannot hold that paper from sliding out, that's a positive Frohman's test, which leads us with a bunch of other clues into maybe it's an ulnar entrapment.
I was turning my hand.
Okay.
It.
Oh, you're cheating? Okay.
I think so.
Yep, because you want to avoid. Show us how we cheat. So you'd bring the thumb kind of in. So when you roll in with the thumb or anywhere across, you're going to recruit the median nerve. So you're cheating with like a different nerve. We want to isolate median nerve. or rule out median nerve and isolate ulnar, which is straight down knife hand, as flat as can be. Yep. Oh no, no, that's pretty good. That it's not big. I mean, these are tiny hand muscles. But if you have someone's barely tugging and you cannot hold that paper, yeah, see which one's better. Now, I don't know if I adjusted your wrist this morning and fixed the carpal tunnel syndrome and everything else. But, no. No. Oh, you see here, if you can get the camera angle, I think it's projected there. See how she's curving her hand in? You want to flatten that. You want really flat knife hand. Perfect. Yep. Is there lotion on there? See, that's good. That's a good Frohman's test. That negative Frohman. It's good because you don't want this problem. So the sheet of paper, that's a clinical test. So as a clinician, we can kind of figure it out. But it's easy too. If you have issues, you're holding papers like that and they fall out of your own hand, that could give you a clue to come in and really get it treated. That's ulnar. So median nerve numbness here with pain in the wrist. Ulnar, pain down the pinky ring side of the hand, the knife hand. And lastly, there's only 3 major nerves to the hand, and they subdivide, but radial, ulnar, and median. Now, ulnar in this thumb picture, I turned it down because the first 2 were at the palm side of your hand, ulnar and median. Now the top side, so a lot of times we'll get like numbness and pain radiating to the top of our hand. We're shaking it out and stretching it, but radial nerve is the 3rd one, and it carries all the sensation on top of the hand. So I'll draw that. So that's top and back of hand. So really the whole thing is green. And we could subdivide between, like, these things branch off like 100 times too. So you get a radial off a branch of a trunk, and then you get divisions, and they all so many different, but really the main part of the hand is 3 different major nerves. But the top of the skin is a control system from radial nerve. So when it's entrapped there's things like, I love it in school, we learn these orthopedic tests like Saturday night palsy. So they're sitting on the back of a chair, which I don't have one here, but I get one. So people come in with, yeah, I'll bring it. They call it drop wrist. Yeah. So I don't know why. Maybe it was way back in the day. We're looking at sailors on ships or soldiers, but people pass out in bars. So they have this thing with wrist drops. So if you have a wrist drop, that's from the radial nerve, because that controls all the muscles that keep your wrist up. So these wrist drops, like a foot drop or a sciatic thing or something, but up here it's a wrist drop. So they cannot extend or control the muscles because the radial nerve isn't conducting fast. It's pinched or compressed somewhere. But they have these hallmark ideas from the 1800s where someone falls asleep in the bar and they're like this. I don't know why they're sleeping in the bar, but yes, they used to, and then they're sleeping like this. They're passed out, and they're there compressing the nerve as it comes by. They'll catch the radial nerve. So they'll wake up out of the stupor, and they can't lift their wrist. They'll have this little T-Rex arm, wrist drop. Because one of the most common entrapment sites is it runs, radial nerve comes out through the back of the arm too. So. You're upgrading? What's wrong with the stools? They fit in the table. Oh, see. Look what I started. I brought out the cushion. So that's radial nerve. So a lot of the back of the thumb or the extensors of the fingers, these all branch off the most common radial nerve. So if you're numb in the back of the hand, and if you do have, maybe it's a little weak when you go up, but a lot of times patients will report pain in the muscles, usually the top of the wrist. So we have we call it tennis elbow. Right? They're doing backhands all the time. That's using the radial nerve muscles. And all the top of the forearm will attach to the elbow, the radial head of the elbow. So all the pain, they'll have this tennis elbow problem or radial epicondylitis. But all those muscles attach to the top of the hand on the top side. So they'll have tendinitis, entrapments, but the most common, there is a part where the radial nerve actually starts out the back of the shoulder. So again, like the bad posture, sleeping, crushing shoulder issue, you can get the two, ulnar and median, from the inside of the elbow, but the back of the shoulder. So if you have this rolled out shoulder, which a lot of us do by default, it stretches over the nerve and actually compresses it. So there's a triangular space peripheral nerve entrapment here of the radial nerve. So if your shoulder's rolled, you got to think about what comes down the top of the hand and the forearm. So we'll have pain in the shoulder and then down the forearm, and then this numbness pattern in the top of the hand. And when we go to the C7. So C7 at the neck part also controls the pec. So if it's unstable in the neck, it's going to slow down and contract the pec. The pec is huge, which has a problem with the nerve coming out the back. If you roll your shoulder, you stretch the nerve in the back, and it's compressed there. But the pec and the is also from the same radial nerve, or it's C7 in the neck. It carries the same thing. So C7, radial nerve peripheral entrapments. That makes sense. I was thinking the most common entrapments for radial nerve, but you could look at things like neutral hand, and you're testing your arm. So you're neutral, not up, down, but like right in neutral. A lot of times we're like, even I was remembering multiple sclerosis. A lot of times they'll have these muscle contractions, and the elbow will stiffen here. And I had actually more than once, like patients having this tendonitis and muscle pain problems from MS. But a lot of times they'll have this neutral. So they'll rip muscles. So I remember one guy was pulling his pants up. He had this incredible elbow pain for a while, and then boom, something snapped, and it ripped this brachioradialis, which is the muscle that actually comes off C6 and traps C7. But it's right here. So the outside of the forearm for neutral hand lifting, you get the shoveling, and because I was trying to remember common provoke things we do mechanical wise that'll really stretch or entrap C7. Besides
Vacuuming?
Yeah, vacuuming. Anytime you're lifting or elbow flexing with your hand in neutral, pulling
I have a lot of
things.
patients that are like, I was just vacuuming.
Oh, that's a
and
good
this
one.
hurt. Or I was just, taking the
Yeah.
trash out, and something I do all the time. But it wasn't really that. It was something long before that.
Instabilities. But that'll be the thing. It's already turned off, and then all of a sudden you go to pull up your pants or go to vacuum, and that part of the hand will just radiate pain. You'll think something died on you, but it didn't. It's just got pinched, and the pain in muscles are tremendously bad. But if we release the shoulder, turn on muscles that hold it back, and go through and really stabilize stuff, it'll loosen the tone of the forearm and the back of the shoulder, and it'll give your skin and reduce pain and give you sensation back. But radial nerve carries the back of the hand. That's the main. So we're looking at pain patterns and numbness from the hands. So should I answer this question coming in? Yeah. So with that, let's see. Common. What happened? So triangular space peripheral nerve entrapments behind the shoulder, hurting the top of the forearm, is extremely common. So I'm trying to think of a case. Okay, so I have one. So anyone that I would say, okay, so any worker that has to deal with their shoulders up, right? Hairdressers, they're always cutting, blow drying, all this stuff up. Or even from anyone photographing or holding cameras, all this drag will happen through the back of the shoulder. It's demanding the body to be more stable to hold it up.
Chefs?
Yeah, anyone with anyone, not just typing kind of down like this, but if you really have to do work where you're holding up in front of you.
Construction workers.
Oh, all the time.
Lumber.
But relief is actually quite immediate. Because if you can turn on the nerve to stabilize it and go through the trigger points, which are pushing over the nerve, relief. It doesn't take a lot of time, several visits, but you'll notice right away immediate relief because you just unpinched it. And it's a pattern of just allowing the body not to keep pinching down on it, but it immediately relieves, which is the easy part. I can go into the shoulder and you'll feel the pain right into the hand. Ah, there's a connection from here to the hand.
There's a complication of median nerve surgery.
Quite often.
Well, I guess what would be complications? You didn't formulate a question.
Yeah, so those when you go see your primary and they send you to a hand surgeon or go from a neurologist then to a hand surgeon, oftentimes there is complications because you're cutting in a very small space. Skinny bones has got, I mean, it's a very, very tiny space. So you have extreme surgeons who can do this handwork. But anytime the surgery, let's say the misdiagnosis is not in the elbow, or it's mostly in the elbow, but sometimes they're thinking wrist. So if they cut in here and it's still numb or it just doesn't come back, or maybe they nick another nerve, they'll blame it on scar tissue. Oh, there's scar tissue there. So, it was good and now your body's forming scar tissue. So you might have to go again and clean it up. They have these cleaning up kind of talks. But the complications could be tremendous because it's so delicate and so small in there that you can nick another nerve, you can really nick a tendon, or you go through the flexor retinaculum, that thing's a mess. So these are issues. Or as all the nerves run, there's a twin artery and veins that pass. So most artery and veins and nerves run together. There's a radial artery, there's an ulnar artery, and you have the nerve sets for them. So if there are complications or problems in the surgeries, you can nick one of those and bleed out in your hand, which is terrible. And they have to go in and sew the artery back. But
so you
from
know that there's a lot that can be done prior to surgery.
Yeah, because the surgery is pretty rare that it's actually entrapped in the wrist. I would always treat more conservative, and then if nothing else works, really go into if that is the thing and have it verified by at least 2 or 3 surgeons. But most of the time I find that I don't see these where they're so bad and it's severely trapped in there that is the only solution. A lot of the times it's a double or triple crush, we call it. So let's say it's a radial nerve and it's pinched in the back of my shoulder, and then maybe I did Saturday night and I passed out at the bar with my arm and I got some kind of pinch into the armpit too. So you have one spot, one crush, 2 crushes, and maybe the wrist is in a funny angle and there's something, and then you have 3. So you have 3 spots. You have a triple crush syndrome. So you can clear up 2, that'll greatly help it. And then if you can actually strengthen or open the carpals in different ways through physical therapy or neuropractic, it can take care of those bony pathologies, which can actually help.
So let's say that someone has had carpal tunnel surgery.
A lot do.
Now they're still having symptoms or pain or issues. Like what's the solution from there? Because my surgeon's going to say more surgery.
Right. Scar tissue. Scar tissue. We got to do it again.
What would you say the answer is to that?
Well, I'd say they misdiagnosed it from the beginning, or maybe it's multiple. Maybe it's 2 or 3 spots that are entrapped. So if there is a true carpal tunnel and they did a proficient surgery and it's open here, but before it gets there, it's pinched in the elbow, or maybe it's even pinched in the armpit, or the neck is really unstable. So we have a lot of patients that come in with surgeries and still have issues from it. So we finish the other entrapments because it's a long continuous wire and it can be problematic at many points in there. If you just go down to the wrist and you help it there, you still get elbow, armpit, and neck to deal with. So, I mean, if you're at the end, just figure it. So that's what we call segmental treatments. So you're looking at the segment that hurts, not knowing where it all comes from, or at least addressing where it comes from. So it could be trapped multiple places.
So one of our viewers has had carpal tunnel syndrome or carpal tunnel surgery and medium nerve surgery, and still unfortunately it's much worse, constant pain, sensitivity, limited range of motion. And she agrees
Yeah.
it's not good from surgery. And then we have another patient that wants to know if you can explain what scar tissue is and what exactly it is and why does it form if it's an actual thing.
Yeah, scar tissue exists. Anytime you cut the body in any way, it doesn't matter if it's the dermal layer, subcutaneous, all like into perennial like organ type tissues. Anytime you cut tissue, it does lay down like fibers that will heal your cut. It's an amazing process in our bodies. But if you have an amount, like a larger amount of scar tissue, because there's a lot of things resected or cut, it will form. And people have different degrees of forming scar tissue. Like there's keloids, right? So keloid can form. You pierce an ear, and all of a sudden, some people will get really enlarged, bubbly type keloidal scar tissue. Some don't. Some people will have a cut, it clears up just fine, and there's no risen or scar tissue in there at all. People have different amounts of making scar tissue when they're injured. It's your body's immune system in process. Everyone has some form of scar tissue. Like when I had ripped my pec when I weightlifted years ago. And when I ripped the muscle back, you lay in these fibers of scar tissue, and they lay in all funny directions, because it is no one direction. Scar tissue lays in like a matrix, like a spider web. So what we did, we didn't want all that weaker fibrous tissues going all over the place. So we did this. We took Rassin tools, which are like little metal bars, and lotion, and you want to scrape it in the direction of the fibers. So you don't want the fibers going up or back or cross-sected the muscle fibers. You want to scrape them to break them out of there and only remain with the tissues that are growing in line with the muscle tissue, because they're contractile. So if my pec would contract closing down this way, I only want scar tissue that fills in the gap that had ripped.
So
I don't want the others to.
Scar tissue is our natural healing agent. That's what our body does when we have an injury.
Yeah.
So then we have surgery to remove the scar tissue. Isn't it just going to cause more scar tissue?
It often does. And that's why it's commonly used as an excuse. Because if you're a surgeon and all you're going to do is do the same surgery, because that's what you do and you don't do anything else, which is great. There's amazing surgeons out there. But they're not going to break down the scar tissue or activate your brain and start looking at other entrapment sites. They're just going to go to that one site, and that's the only thing they got going. So they're going to say, well, it's making scar tissue. We're going to go in and clean up the other scar tissue. So once they open your wrist again, they're going to see more scar tissue, and they're going to take a scalpel and remove that scar tissue. But the thing is, your body's healing. So anytime you open up your body to the environment, it's going to lay down more fibers and start to close the skin again and make more scar tissue to do that. You can reduce it with many, like oils will help the greater formation. You want a little bit of healing tissue in there, but you don't want too much, or it's scarring and it's non-functional. It's just keloidal like. So you can do what are some of the oils? Remember, is it called
like essential oil?
yeah, but the thick one that people use
castor
for
oil.
Yeah, castor oil is a good one. If you look at Barbara O'Neill, she talks a lot about. She's a naturopathic doctor. I think she's Australian or British, but she talks about castor oil for everything, especially scar tissues. So she'll soak in scar tissue or castor oil. So if you had a surgery, if I had a patient that had their flexor retinaculum cut in half, and they're claim that the scar tissue is still why that's not working perfectly or ever fixed it. I mean, we'd fix it by fixing the rest of the entrapments, but you can clean up scar tissue by putting castor oil on it. And you can do a lot of things like ozone water. Some of these oxygen really helps scar tissue formations to reduce or not form. So your body can heal good epidermal or dermal tissue instead of scar tissue, which is just a bunch of like a matrix of fibrogen and all this. And they're just not good contractile tissue, and they don't do good with anything else. They're just like a filler almost. So you can do with your better immune systems, or use oils, or like I did with the pec, you can scrape out the formation of the scar tissue building up. You can really break it down, actually.
When you say scraping, you're talking external scraping, not
Yeah.
internal.
And when they go in, they're just, you go inside your body, it will make scar tissue. It protects us from the outside.
So So you can use different tools to scrape with. It could be a stone, it could be a rolling, like what kind of
Oh,
tools
yeah.
do you use to
We have,
scrape out something that's intact?
yeah, there's Graston tools, there's wooden dowels. I have tons of them in the office in all the rooms.
We're creating a product we're going to be able to sell to our friends and patients soon, so
Yeah.
it's going to be great.
I'm very excited about it, and I would love to go into detail about it. But it actually, this tool that we're looking at is my favorite, because when most of the tools you use, they're one sharp edge and it's kind of tender. And when I was Grastoned out with these like butter knives or these metal bars, and we're just stripping my pec, which actually, I mean, it ripped previously, it hurts. And you have that one point contact, and it's just ripping across. Yeah, there's better tools, but tools help facilitate the breakdown of the scar tissue. It's okay to break down scar tissue externally, no problem. It'll reabsorb and you'll be fine. That's a really good technique to use. And use oils like castor oil, which they can really penetrate deep, and they have great properties in breaking down scar tissue like that.
So I don't know if she left already, but the patient that was on that had the carpal surgery, there are things that doc can help with to relieve that pain that you still have. So don't give up hope. You can come in and he can work that out for you. Just shoot me a text or call the office and we'll get you in, and I'm pretty sure he can help you relieve a lot of the pain that you are feeling still.
Yeah, there's lots of carpal tunnel surgeries, lots of hand surgeons doing work. It's tons out there, but it's only a piece of it. So, I mean, if it's misdiagnosed or there really was a part, there's more to it than that, and we can complete it. Because as a neurologist, I look at all those, I know all those intricate parts of where they could be entrapped or muscle tone.
He can help you strengthen it, and he can also, when it does flare up, if you feel good for a little while and then it doesn't feel good again, and we get disappointed and we get down, that it still hurts. There's tricks that he can teach you and exercises he can give you to help you in the moment when it's really bad. So
yeah, because the main thing of why it happened, where you compress a nerve, is a dysfunction. Something's not functionally moving correctly. And as we stand with spinal cord posture muscles, everything is nice. But sitting on a desk for 12 hours, it changes. So you're demanding muscles to be stronger to hold your posturing, so you don't default into flexion posture. Because when you do, that's where the entrapments come from.
Or where you're laying in bed and you're watching a show on your phone and you're turned over on your side and you're like this and you're laying down and all this gets entrapped.
Yeah.
I didn't do that yesterday at all. Then you wake up and your arm is hurting. Those are all the things that are just our normal life today.
Yeah.
Texting, when you're texting 300 patients in the morning to remind them of coffee with doc, that's kind of what happens in this region here. So.
Oh. And we saw it over COVID. Everyone's home. They're not walking around outside doing normal life stuff. So we're home on our phones, stuck there in these postures, and the amount of jaw pain and headaches and pinched nerves, they were like on the quadruple fold.
And a lot in our teenagers, our young people who weren't normally
it hit them
all
hard.
The tech during 2020, 2021, we were seeing all kinds, and we just kept saying, get them off their phone, get them off their tablets, because that's what's causing all their light sensitivities, all the sound, all the stuff. So
VOR reflexes. I think our brain was maximized in the 90s. We just had the simple flips, and that was it. Technology was at its best. And now it's just too much for our brain, and it's fatiguing, and we just collapse in, and it's just a mess. But the thing is, so you want to reduce the entrapments, you want to strengthen the muscles back. We have NeuroGym. So you extend, you do deep neck flexors, and you extend your head. I created a whole bunch of programs and muscle activities to straighten posture, so you don't keep going back into the same default. Because you're going to go to work for 8 hours, 10 hours. You're going to sit at home, maybe watch your phone like this. All this life stuff happens. But if you strengthen over the top of it, not only like fix a nerve and entrap and get going, but then fix the posturing problem by turning on cord muscles and strengthening. Because like, for instance, shoulders, head, and neck, pecs are huge. They're very strong, and they're going to pull you forward. All the little guys in the back are going to have issues, and they're going to be overpowered, and that's what creates a peripheral nerve entrapment. So it's bad posturing and brain dysfunction that creates a pinching out through nerve time. So if we strengthen over the top, you have reduced, the angulation's good, and you're not compressing. You're long and strong and healthy, and you're not, and you can endure a lot more. You can sit for 8 hours if it's stable and not default in some kind of flexion posture that the brain is doing. Because the brain by default, if anything turns off in the brain, spinal cord, muscles, it'll collapse you. By default it is. In the brain there's more flexors than extensors, because we start as a fetal baby and all our development from 0 to 2 is a fire extensor tone and come up. And as we age and our brain gets slower and we're not using it, then we go back to baby. That's the default position in our brains by design.
That why we see a lot of elderly people like.
Oh, absolutely. Yeah, they're never aging extended.
They like the floor or something. Like they can't.
It's a combination.
With balance and stuff. Because like my mom right now, she's having a hard time standing up after the hospital from being in the hospital bed for so long. And she's like has her head so forward, and we're like, Mom, you have to stand. But I think she wants to see the floor maybe, and so she's bent over. And I'm like, I don't know. Is that what happened?
This is a great segue because in 2 weeks we'll do Coffee with Doctor again, and we're going into vestibular systems, vertigo, and balance. And we're going to break that down entirely. But as we age, our brain as a whole piece does, and what you start to lose are your reflexes for balance. So when you can't feel your feet as well and you don't have this great posture, you have to recruit your eyes more than most to look down, because you can't feel it or have that great balance unconsciously with your eyes closed. You're going to have to stare at it because all you got left is your eyes. So they watch their feet and their bodies fall into it. So they're having to watch their feet because they don't have the good feedback in brain because it's slowed down. So they can't just walk through space knowing where their body is from proprioception. So they have to recruit their eyes, and their eyes are failing too. So they have depth perception issues and they can't judge where they're walking. So they have to heavily watch their steps, and they're looking, like let's say you're walking downstairs, you're stepping over something. They really have to be able to judge that. And if you're losing depth perception now, you can't see it with your eyes either. So they're always misjudging something, and now they don't have the balance from the feedback from the legs, and they collapse. So those falls are huge for super seniors.
So you activate brain and all the exercises you do in brain, and then we have a reduction in that?
Absolutely, because I'll look at all the reflexes, and eyes, ears, and feet give you balance. And knowing where your brain unconsciously knowing where your feet are, judging depth so you can connect and stabilize, and your inner ear for balance canals. And they usually have all these starting to break down.
So when older people slouch for years, how reversible is it? Is one of the questions.
Easily. No, barring that there's like
it takes some work, you always underplay some stuff.
Yeah. But barring that they have like a 50-degree scoliotic curve or a massive kyphotic curve, so at the spine they're like this and they have to look up like that. I mean, you can catch that eons before, so it's not just how their body has to be. They did some brain work and activated balance canals, they turned on these muscles, they wouldn't have succumbed to our, what they call you're just getting older. No, there's an actual dysfunction that happens, and the longer you allow it to happen, this is the default, where everyone is like this looking around. It's completely reversible. But let's say you catch it, you're mid-70s, and you have the kyphotic curve and some scoliosis and an inability to look up, and maybe some old shoulder, like rotator cuff injuries, and surgeons went in. You can still get this back to a functional part. You can get some extension. You can definitely reduce the pains, and you can reduce the entrapments and the numbness. But the big thing is getting your brain to see where you're walking and have feeling of where your feet are, and not fatiguing in the balance canal. Like you turn your head and all of a sudden you lose your... There's a lot of systems we'll go through in 2 weeks, but like how far? My hand in frame? Yeah, right. Okay. So the inability to... You see this a lot. Someone's walking, and all of a sudden they look at something and they start drifting. That's a reflex in brain that we look at all day long. Eventually, I have patients, I get them on balance boards that are electronically moving with lasers on their heads, and they're doing targeting and complex movement patterns.
Going to the arcade.
Oh, it's so much fun. But you'd be surprised who if we build them up and strengthen their brain, what they're coming from is they can't even stand one leg without falling down, to where they can stand on a balance board and they can do these complex things. They are not going to fall walking out of their house with their groceries.
Another question as we start to wind down, it says, does spinal stenosis have anything to do with the medium nerve entrapment? Is there treatment for spinal stenosis?
Yeah, because so when you look at spinal stenosis, it means on some kind of image, like a CT or an MRI or something, that the side of Skinny Bone Jones, so it's a spinal, so it's the canal where the spinal cord is, and it's a measurement of, and there's a standard normal amount of room that the cord has to have in there. And when they measure it in an imaging, I think it's somewhere between like 7 and 11 millimeters in the neck, and the holes at the lumbar are much bigger, so they allow for like 15 to 17. I'm not sure on the exact numbers, but it's just a picture that tells you what the average person has in space in the spinal cord, or has an opening within the bone where the spinal cord will run. So you can have spinal stenosis and have no dysfunction from it. You can be very great, just have a measurement that looks wrong and nothing wrong with you.
So is that way when people kind of like, oh, it's bone on bone, it's grinding, it's because they lost the distance between the vertebrae?
Oh yeah, bone. You could lose a disc. I don't have 5 of mine in my mid-thoracic. I had Sherman's disease, which is, they call it avascular necrosis of the spine. But as you're developing, you have a very cartilaginous kind of rubbery spine, the vertebrae, and the blood supply has to get there, and the phosphates and magnesium, calcium to harden the bone. And if the blood supply isn't sufficient, it's going to stay soft too long. And I have this rubbery back, and I was a hard kid running around and jumping and stuff. So I just eliminated those discs. It just crushed them out. And I never knew. I had no symptoms of my loss of discs or anything. I probably lost 2 inches in height. Never knew it until I got into my doctor in chiropractic. They had to take x-rays because we were going to start adjusting each other. And they were like, ooh, that's terrible. What is this x-ray? It looks awful. And I'm standing there like this. And they're like, you don't look like this picture. You're not Skinny Bone Jones with no discs. Actually, he's better because he has very nice discs, but I don't have any in the middle of my thoracic. As long as the nerve has enough room to come out of the side, that's a foramina, and that's a spinal nerve. There's plenty of room made in bones for that too. So it's not judging. So, but basically, a lot of these are terminology to scare patients to do surgeries or something.
So if I was told I have spinal stenosis, it's up here. Could this spinal stenosis cause my carpal tunnel syndrome? Or cause me pain down here? Well,
in extreme
entrapment, right? Entrapment here, entrapment in the elbow, or the shoulder, entrapment in the elbow down to the wrist. So it could stem from there, but it could stem from the other parts too.
But I would say, so you would look further. So you have the space where your cord and nerves run. It's smaller, but is there nerve signs? Is there spinal cord signs? In an MRI, do I see the spinal cord actually change, have white dots in it? Is it atrophying? If you get a cervical spinal stenosis, are you peeing your pants? Do you lose your bladder control? Do you have spastic arms? And you will know when these things are severe and they're actually causing something other than just some labeled measurement in your neck.
I would hate for you to think that because maybe you were told it was in the spine here that you do surgery here to fix this.
Yeah.
And we see that a lot. I know personal family members who have done that, and it just doesn't work.
Well, Johns Hopkins University every year puts out the low back papers, but they're really looking at the whole spinal column. They're neurosurgeons, and they put it out every year. The first thing they say in this study is we don't really know how it works, but this is how we think. And they go through stenosis and all these bony issue problems because they only do surgery on bones. So when we're looking at entrapments and median nerve stuff in arms, bones and wrists or bones and neck, that's all they go to, and they're missing most of the stuff. But if that's what I go through in an exam as a neurologist, I can tell if it's a pathology in the neck and you're compressing nerves there because there's bigger issues, which is more rare, or if it's maybe in the shoulder or anywhere in that pathway, that nerve. I can tell where it's going to be because we do a good in-person exam. A surgeon doesn't do exams. And the neurologist is the one that would do the workup, but maybe that's not so great. Every surgeon could be different. Every medical neurologist could be different, but they don't look at the details as much as a functional neurologist would, because we're testing in exam old 100-year-old exams that were really good, which they don't really do now. They rely on imaging. So I'm going to take a picture of your neck and tell you that's the problem, instead of just testing the nerve or looking at the muscles or looking how your brain is feeding it, or being able to tell from a neck to a shoulder, a brachial plexus, or a nerve that's pinching muscles. They don't really do the workup. And nowadays, like the old country doctors used to do a lot better, but we rely on too many imagings now, and imagings aren't that great. So you got a person in front of you who has a really good reflex. So let's say the bicep tendon reflex C5 has a lot to do with all the shoulder tone and neck tone. And if they tell you, oh, C5, you have a stenosis there and there's this issue and it looks really bad, you got a good reflex, the nerve is not bad. There's no atrophy in the muscle and the numbness patterns aren't so bad, you don't need surgery.
All right, so our time's up, unfortunately. And we just wanted to thank you for coming out. We have a lot of fun things going on here at the clinic. If you ever want to join us live for a Zoom, we're here. We provide coffee. It's good.
Yeah.
We
That's
have
your little treats too.
Neurogym, hyperbaric chambers, massage. We have amazing therapists. We have some new students that are coming in, and we offer 20 minutes for $20. Super deal.
Yeah,
while you're
super
waiting,
cheap.
waiting for Doc and your appointment. So a lot of fun things coming up, but let your friends, let your family know. That's really how we market, is through word of mouth, because someone has to explain what doctor does to you in order for you to understand it. So brain, nerve, muscle, bone. Bone's always last in his opinion. So we're super excited for all the things that are coming up. Much appreciated. Many thanks for your response to my questions. Absolutely no problem. Hope to see you here with us soon.
Functional, that's why we do these, because nobody really practices function. I mean, medical neurologist does not do function. They look at pathologies and they refer for surgeries or give you nasty drugs. That's what medicine is, but that's not how healthcare is. That's not healthcare. Healthcare has a lot of arrays of like preventative medicine people, and we're one of those. So in functional neurology, no one's out. There's very few of us, and no one's out there really getting it out. So I wanted just to educate. That's why we do this purpose.
Thank you. We'll see you in 2 weeks, every first and third Saturday. One at 9, one at 6. You have the little. I think I've texted all of you the upcoming dates through March, so put it on your calendar. It's the same Zoom link, so you can always use the same one. I can always send it to you again, though.
Yeah. We're doing, Neurogym we started up is doing really well. People like it, and I love doing it. That's at 4:15 Monday through Thursday here for 1 hour.
Yeah.
But
$75 a month, super cheap.
Yeah.
You get to work out with Doc. And you can do one-on-ones too. We have different memberships, or just one-time one-on-one. He can teach you, and then you can work out at home without hurting yourself, hopefully. If you do it right.
Yeah. Oh, that's a good point.
So.
Well, that's it for today. Next week we're doing vertigo, disequilibrium, and balance issues.
I believe. Are you getting the balance board out here next time?
Oh, that's a great idea.
That'd be fun.
I got to get the lasers.
Let me know if stand on the balance board.
Yes.
Okay.
Beautiful model.
See you soon.
Right. So I am Dr. Brock. I won't crack you up, but I'll get on your nerves.